Hi, my name is Amy Ford, and I would like to welcome you to Competence in Cancer Care, What the Nurse Needs to Know. Today's focus is going to be on health promotion and professional performance. We are first going to look at health promotion, and then towards the end of the talk, we'll review professional performance. In order to understand the need for health promotion, it's important for us to understand the global cancer statistics. As you can see by this slide, by 2030, deaths from cancer worldwide are increasing with an estimated 13.1 million deaths. Specifically, the majority of those cancer deaths are related to tobacco. 22% of global cancer deaths that encompass every different type of cancer are related to tobacco, as well as most specifically, 71% of tobacco-related deaths are related to lung cancer. And the global cancer incidence is going to increase to about 75%. Lung, stomach, liver, colon, and breast are some of the most cancer-causing deaths each year. And about 30% of cancer deaths are due to 5 behavioral and dietary risks. If patients have a high body mass index, a low fruit and vegetable intake, lack of physical activity, tobacco use, or alcohol use. Other things that cause cancer are viral infections such as the hepatitis B and C virus, as well as the human papillomavirus. Those are responsible for up to 20% of cancer deaths in low and middle income countries. If we look at the 2012 estimated U.S. cancer cases, we see that the American Cancer Society regularly updates these facts and figures, and this presents the most current trends in cancer occurrence and survival. As you can see here, men and women, the number one most estimated U.S. cancer cases between them are prostate and breast, and then equally the same you see here with lung and colon, with 14% and 9% of the population. It's important for us to understand the epidemiology definition. Some of you may remember this from nursing school, but we know that the cancer incidence is the number of new cancer cases in a specific site or type occurring in a specified population during 1 year's time. So you can see here it's expressed as a number per 100,000 people. So incidence is more what is happening in 1 year's time versus cancer prevalence is the number of people alive on a certain date in the population who previously had the diagnosis of cancer. Either both new and existing cases, or it's a function of past incidence and survival. So all of those people alive on a certain date in the population. If we look at primary cancer prevention, we know that primary prevention is focusing on risk, which is lifestyle changes. What lifestyle changes can be changed for our patients? Helping patients with not smoking is an example of primary prevention. It's thought that about 80% of all cancers are related to smoking, and we saw that with the global cancer statistics. Often we think of lung cancer or head and neck cancers, but cancers such as stomach, kidney, bladder, and others have been linked to tobacco. Alcohol increases the risk of liver cancer. Multiple sex partners may increase the risk of HPV, while same-sex partners increases the risk of anal or cervical cancer. Obesity has been thought to contribute to many different types of cancers, including breast, prostate, and colorectal, just to name a few. So changing these lifestyles, and this is under primary prevention, can decrease the risk of developing cancer. We also have secondary cancer prevention, which is the early detection of the disease as best as we can early detect it, and that is with the use of screening and diagnostic examinations. So you see here the picture is the mammogram and encouraging women to start getting a mammogram at age 40. Other examples would be the PSA test for prostate cancer. Unfortunately, though, there are many unchangeable risks as far as cancer prevention, and you see here in the bullet points their genetics may put them at a higher risk for developing cancer. Past exposures in their lifetime, such as frequent sunburns as a child, that could put you at a higher risk for developing skin cancers. The aging process, the importance of family history. It's important to understand family history, but what we know is there's just some things we cannot change. It's interesting to note different ethnic group differences, that if we look at lung cancer, we know that African American men have a 50% greater chance than Caucasian men of developing lung cancer. You see here with cervical cancer, there are higher rates in Vietnamese women. And then with stomach cancer, Asian and Pacific Islanders have 2 times the stomach and liver cancer incidence and mortality than Caucasians. This is a chart showing you different carcinogens and the related industries and the cancers that they may cause. I would refer you to cancer.org, the American Cancer's website, where there's a more comprehensive listing of carcinogens. We are now going to look at different types of screening tests that can be done to help prevent different types of cancers. And this first one we're going to look at is for prostate screening. We know that the prostate-specific antigen test, or the PSA, and the digital rectal exam, or the DRE, should be offered annually at age 50 if there's a life expectancy of at least 10 years. We know that men at high risk, such as African American men and men with a family history, such as a direct relative, meaning a parent or a sibling, that the testing should begin at age 45. What are some specific things you need to know before a PSA test is drawn? Do not ejaculate for 24 hours prior to the PSA screening. Have the lab work done prior to the digital rectal exam. Inform your doctor if you're on any other medications, as these things may artificially elevate or decrease the PSA. Lung cancer screening has not yet proven to prolong survival, but we know there are lots of clinical trials and data looking at, is there a particular screening tool that can be done to help with the prevention of lung cancer. Some feel that targeted screening of former and current smokers may be useful. So what I would encourage you all to do is to find a clinical trial if you're at high risk for developing lung cancer, and getting on that clinical trial so that maybe someday we can have a cancer screening tool for lung cancer. If we look at colorectal cancer screening, we know that beginning at age 50, a fecal occult blood test needs to be done every year, a flex sig every 5 years, and you can see the listing here. And I think colonoscopies, and with Katie Couric, who is a celebrity who has made it a part of her mission for early detection, we have seen so many patients now be diagnosed earlier with colon cancers than ever before. And this just shows you the tools that if we encourage our patients to undergo the screening, we can help with early prevention and intervention. Another screening tool is the breast cancer screening tool. A yearly mammogram is recommended starting at age 40, and you see here a clinical breast exam every 3 years for women in their 20s and 30s, a clinical breast exam every year for women 40 and older, and that a self-breast exam is now considered optional for women starting in their 20s. But it's important for us to encourage our families, our friends, and our patients to make sure that they undergo their yearly mammogram. Some additional screening tools for gynecological issues, for cervical cancer is a Pap test or Pap smear. Should be done annually, especially when there's a change in sex partner. For endometrial cancer, it's very important that if a woman has reached menopause, that she reports any unexpected bleeding or spotting. And you can see here with ovarian, we really do not have a helpful screening tool, but periodic pelvic exams are helpful. A great acronym that we can help teach our young adult male population, specifically those males between the age of 20 and 34, is the testicular self-exam to screen for testicular cancer. This is a good acronym, the TSE, which stands for Timing, Shower, and Examine, but that they would, for once a month, for about 3 minutes in the warmth of a shower, relax their scrotal sac, and then examine to see if there are any changes and report those changes. Another health promotion initiative is Melanoma Monday, and the idea with this initiative is to help people to go get their skins checked for a full head-to-toe skin check. And I like what it says here at the bottom of the slide, check your birthday suit on your birthday. So if you do not go for a yearly evaluation for skin checks, for a head-to-toe skin check, that you would maybe go the first Monday in May, right before the summertime, and that you would get regularly checked once a year to help prevent skin cancers from developing. So what is your skin type? This is the Fitzpatrick model. Dr. Fitzpatrick was a dermatologist from Harvard. He developed this back in 1975. And what's important about this is understanding your skin type, and dermatologists actively use this in looking at the susceptibility for patients for developing potential skin cancers. A level 1 is always burning easily, from a level 6, which is never burning, because they may have deeply pigmented skin. And so it's important for you to understand what your skin type is and for us to avoid the sun. In Australia, there's an initiative called Slip, Slap, Slop, and it's a great initiative because you slip on your protective clothing, you slap on your hats and your gear, and you slop on your sunscreen lotion. But did you know that a white t-shirt, you'll see a lot of people protect themselves from the sun by putting on a t-shirt. It only has an SPF of 4, and we know we need a higher SPF in order for sun protection from the UVA and UVB rays. We want to make sure that we avoid the sun from 10 to 2 every day, that we apply sunscreen 15 to 30 minutes before we ever leave our house, that we wear broad brim hats, and that we protect ourselves as best we can, and specifically that we apply a good amount of sunscreen. And what's recommended is at least 1 ounce of sunscreen is needed for protection. If you see that there are any abnormal moles or freckles that you have, if you do frequent skin checks, which is recommended, there's the ABC acronym, or the ABC rules for preventing skin cancer. A is for asymmetry, if the mole or freckle is asymmetrical, if there's any irregularity to the mole. B is an irregular border as well. C is color, if you notice 2 different color patterns in the freckle or the mole. For example, if it's a light black to a dark black, or a light brown and black mixed together in one freckle or mole, that would be concerning and cause to go in for a skin check. D is diameter. If the size of the mole or the freckle that you see is greater than that of a pencil head, which is about 1/4 of an inch, you would need to seek attention and seek someone to do a skin check for you. E is an enlargement. So if you find that the mole is growing, then you would want to seek someone to look at your skin for a skin cancer check. They've even added on F, most recently, called feeling, and that is where if the mole becomes itchy or just does not feel right, then that would be something you would want to go seek a general practitioner for, or a dermatologist for a skin cancer check. In order to understand different screening tests, for example, the prostate-specific antigen or the PSA test, we know that there are different attributes of a screening test. The sensitivity is the probability that a test will indicate disease among those with the disease. We know that specificity is the probability or the fraction of those without disease who will have a negative test result. And then we also can look at the positive predictive value, which tells you how likely it is that you actually have the disease if you test positive. And the negative predictive value is how likely it is that you actually do not have the disease if you test negative. We are now going to move on to professional performance and issues within oncology nursing. The Oncology Nursing Society has developed different standards under professional practice issues. They develop standards of patient and public education. They have scope and standards of advanced practice. They develop position papers with different timely issues within the healthcare field. They have standards of oncology practice, which are standards of care and standards of professional performance. I would encourage you all to bookmark ons.org. This is where you will find plethora of information from different publications to joining the ONS group to understanding these standards and positions and learning more about the specialty. More specifically, if this is a listing of the standards of care and the standards of professional performance, you can see here the standards of care basically are the nursing process from assessment to evaluation. But we know specifically they've added on complementary therapies, palliative and end-of-life care, and survivorship. Cultural competence is being sensitive and responsive to issues related to culture, including translation of knowledge into credible behaviors and actions. It's important for us to understand different cultures and ethnicities. Competence implies having the capacity to function effectively as an individual and an organization within the context of the cultural beliefs, behaviors, and needs presented by our patients and their family members. Culture and language definitely influences the health, healing, and wellness belief systems. It influences how illness, disease, and their causes are perceived, both by our patients and their family members, and by those who are seeking health care and their attitudes toward us, the healthcare providers, as well as the delivery of services by the provider who we as nurses and physicians, we look at our world through our set of values. As I say, I look through it through my lens, my set of eyes, which can compromise access for patients from other cultures. So it's important for us to understand different cultures and their backgrounds, specifically because the increasing population growth of racial and ethnic communities and linguistic groups, that they each come with their own set of cultural traits and health profiles. It can present a challenge to the healthcare system. So the provider, us as the nurse, and the patient each bring their individual learned patterns of language and culture to the healthcare, which must be transcended for us to achieve equal access and quality health care. And that is the main goal, that no matter where you are from, that we are going to give you the best care that we can possibly give you. It's important to understand about different ethnic groups, and we know specifically that with Asians and Asian Americans that they believe that others come before self, and that they often use self-control when expressing their emotions. In the Latino population, that they may avoid eye contact of the healthcare provider, which may be a sign of respect. They may not ask any questions or express opinions because that may be done out of respect as well for the practitioner. We know specifically with rural Americans that they may travel great distances for cancer care, and so I think we can appreciate this where it says, slow down. Being in a hurry may be considered rude, so it's important for us to slow down, to assess our patients, ask them how they're doing, look at them eye to eye, and be very careful about their understanding and not to run at a very fast pace. And for Native Hawaiian and Pacific Islanders, we know that the elders are held in high regard and esteem, which may mean that the patient may not be making the entire decisions for the family, but maybe it's the eldermost person in the room or in that family. And that their fundamental beliefs often include an affiliation with the supernatural. And we know that spirituality is a leading issue with cultural competence and understanding different cultures, because we know that that's a huge driver as far as people's choices in the care that they choose, specifically with their spiritual backgrounds. With our lesbian, gay, bisexual, and transgender population, it's important to note that they may fear or have experienced discrimination or have a negative attitude. This second bullet point to me transcends all cultural competencies, but knowing that we need to have dignity, respect, confidentiality, and privacy, that is critical with our patients, and that the next of kin may be an issue, so we need to be sure to ask about a contact person. It's important for us to understand cancer disparities and know that those are defined by age, sex, race, ethnicity, income, geography, education, or other characteristics. What you may have seen over the last few years is the use of evidence-based practice, which is the use of current best evidence in making decisions. It's a systematic appraisal of best evidence available. And the Oncology Nursing Society has done a wonderful job of utilizing the evidence-based practice model and putting it into place. And so I would encourage you once again to bookmark ons.org in order to go to their website to see what they have researched as far as evidence-based practice and the interventions that we use in oncology every day. This looks at the model specifically. It's a stoplight color model from ONS that describes different levels of evidence, which we know it's a concept in which healthcare is provided based on the best available evidence in order to affect the best possible patient outcome. Instead of doing what we've always done, interventions using an EBP model rely on science and research as well as individual patient preferences and values. ONS has developed putting evidence into practice resources, including assessment and measurement tools, ideas for patient care and organizational use, and case studies to illustrate application of the tools. The goal of these resources are to facilitate application of current available evidence into everyday cancer care. And the model correlates with the stoplight, where green means go, yellow means use with caution, and red means stop. So if you see here on the slide, green means the interventions are of the highest level of evidence, which supports consideration of these interventions in practice. Yellow means that the interventions have less research to support their use. So you can see they're labeled benefits balanced with harms, or effectiveness not established. And then red would mean stop. It means interventions either have very little research to support their practice, labeled effectiveness unlikely, or have been found to be ineffective or even harmful, labeled not recommended for practice. So it's important that we understand this evidence-based practice model. Within these resources, you can see here a listing of several interventions that we use every day in our oncology practice, from anorexia to depression to fatigue to prevention of infection, sleep-wake disturbances. And you can go to the ONS website and download specific treatment sheets that show the different interventions and whether the interventions we use every day are recommended for practice, if they're not recommended, if the evidence is just not there. So I think it's great, useful information that you all could use in your institutions and in your clinics every day. We are now going to shift and look at understanding the different phases of a clinical trial. It's imperative that the nurse understand the different phases of a clinical trial, and that they would be an advocate for their patients, and that they would encourage participation in clinical trials, because we know that participation may help others by contributing to medical research, and it also helps us to get our drugs faster to market the quicker we can accrue our patients onto trial. So a phase 1 trial is the start of looking at exploring the safety and efficacy of a particular drug. If that drug has shown safety and efficacy, it will then move on to phase 2 trials, where then it is explored effectively in a specific tumor type. If it proves itself effective in that specific tumor type, the clinical trial will move on to phase 3, where the drug is now compared to the standard of care or the standard therapy in a particular tumor type, particular cancer. And if that drug either meets the same results as the current standard of care or exceeds those results against the standard of care, that is when a drug can become approved by the FDA. Normally with phase 3 trials, it usually takes 2 successful trials required before a drug or treatment is approved by the FDA. And it's after phase 3 that a drug company has filed their application called a new drug application, an NDA, in order to get that drug approved. Phase 4 trials are not often done. They basically add to the information. A drug is already FDA approved once it's reached phase 4, and it simply is adding to information such as their package insert with maybe side effects or risk, just more information that they could add to their labeling. Research trials take millions and millions of dollars, plus they take many, many years to go from a phase 1 to a phase 3 trial in order to get the drug approved. It's important to note that a phase 1 trial has a small accrual of patients, so you may see only 15 to 30 patients accrued on this trial. A phase 2 trial may accrue from 100 to 300 patients. A phase 3 trial may have from 100 to thousands of patients on trial. And then once that drug is approved, phase 4, those patients may have, or those trials may have several hundreds to thousands of patients. It's important for the nurse to know essential elements of a clinical trial, that it's a clearly stated testable hypothesis, that there's a well-defined primary endpoint in each trial that's done, that there's an adequate power to answer the different study questions, and what's most important, I think, for the oncology nurse is appropriate and timely patient accrual, and helping with patient accrual, encouraging patients to accrue onto trials, because the more patients we can help accrue onto trials means the more drugs that we will see to market, and that can help the population overall. It's important for the nurse to understand her role in the informed consent process, and this is an ethical issue that you will see in oncology nursing, but we know that informed consent is a decision made freely by the client or the patient after full knowledge and understanding of the risk, benefits, and available options about treatment alternatives. So it's the nurse's role that they remain as a patient advocate and that they make sure that the patient does have a full understanding, and it's the practitioner or the physician's responsibility to go over all the risk, all the benefits, and all available options about treatment alternatives. Different legal issues that I would have as an understanding as a nurse, knowing that there are different nurse practice acts in each state, that there are different professional standards of practice, and I would specifically be aware of your institutional policies and procedures. Under liability, definitions of negligence, the deviation from the acceptable standard of care. Malpractice is the deviation from a professional standard of care, and the duty is the care relationship between the client and provider. For professional development, you as nurses began as novices when you entered out of nursing school, and now you are experts in the fields that you all practice in every day. If you're going to be sitting for the oncology certification exam, you have over 2,000 hours of oncology expertise. You acquire and maintain current knowledge in your oncology practice. You participate in formal and continuing education. And what that does overall is it contributes to the professional growth of others. These are the different oncology certification exams. At the generalist level is the OCN exam. If you have an advanced or master's degree, you can sit for these tests as well and these different certifications. There's a pediatric certification. There is a breast care certification. That's a new one that just came out. So if you specifically are a nurse in breast oncology, that may be a certification test that you would like to achieve or take. ONCC.org is the Oncology Nursing Certification Corporation. I would encourage you all, if you're going to sit for those exams or are interested, that you would bookmark this website because it will give you all the information. We know that it's important for us to work together as a team and that we cannot do our care alone. And with oncology patients most specifically, it's a collaboration of a team of nurses, the physician, a social worker, maybe the surgeon, chaplain, dietitian. In a large area or large center, you may be fortunate enough to have all these different multidisciplines. And it's important for the nurse to assess the patient, to be able to discuss these things with the patient, and then if they feel the need to delegate it to other specialties. With patient advocacy, we understand these definitions. Beneficence is the principle of doing good. Non-maleficence is the principle of doing no harm. And consumer advocacy is what you as nurses provide every day, that you provide the client with information to make a decision, and then you withdraw so as to not unclearly bias the client. And that's what's most important, that we're there as the advocate, but that we allow our patients to make their decisions. They see life differently than maybe we do, and they may have different reasoning for the decisions that they make. Quality improvement is systematically evaluating the quality of care and effectiveness of oncology nursing practice. It's important for us to understand that we have standards of nursing practice and that we have a professional responsibility to assure quality control and improvement. In summary, we reviewed health promotion. We looked at different global statistics, different epidemiology definitions such as incidence and prevalence. We understand now that primary cancer prevention focuses on lifestyle changes and risk factors. Secondary cancer prevention focuses on screening. And we looked at all the screenings for major cancers that the American Cancer Society guidelines have put into place. We reviewed, lastly, under professional performance, that the Oncology Nursing Society has developed a set of standards. They also have cultural competence definitions that we need to understand. It's important for us to understand different ethnicities and the backgrounds that they come from. Having a good understanding of evidence-based practice and the model that is used. Understanding the differences between a Phase 1 trial, which is a smaller accrual for safety and efficacy. Phase 2 is just looking at the effectiveness in a specific tumor type. And then phase 3 is where the drug is looked at versus the standard of care. We reviewed some ethical and legal issues, and most importantly, we understand that we are patient advocates and it's best for us to help with quality improvement. So I'd like to last leave you with, in order to be a good promoter of health and to perform professionally, that you take care of yourself. So these are 10 tips for taking care of yourself, from having a bubble bath to taking a nap, but basically taking time for yourself, because in order to take care of yourself, you can be the best professional you can be, and you can take better care of your patients if you take care of yourself. Thank you. Listed below are some web resources that you may find helpful in your study of health promotion and professional performance.